really excited to talk about feeding. So we are going to get started. Everybody had a lot of great questions about feeding and picky eating. And even if my child doesn't have autism, is that something that you see in regards to picky eating or restricted eating? And it is. Feeding challenges are actually more common than people realize. Um, you are not alone. So here's our stat, right? It's estimated that up to 45% of neurotypical and 80% of neurodivergent kids have feeding challenges. I share this because oftentimes parents of children struggling with feeding challenges feel really isolated and like they're on their own island, and it's the only one that's dealing with this difficult because it's not often advertised. And so the reality is a lot of families are struggling with this, whether they have an autism diagnosis or not. So let's look at this diagnosis of ARFID. I imagine some of you might have heard of this, others of you may have not. Um, the full name is Avoidant Restrictive Food Intake Disorder. It's typically present in childhood, although in some instances, typically due usually to food trauma like choking, adults can develop ARFID as well. Um, One of the criteria when you're looking at having this diagnosis is a lack of interest in food or eating. This is a big one because many parents often struggle to know if they should be pushing their child to eat, if they have a child that just isn't looking hungry, constantly says that they don't have an appetite or they don't want to eat. It is essential to work with a professional to establish appropriate nutritional intake for that child so that you can come up with a plan on how you're going to achieve that. One of the other criteria is avoidance based on the sensory characteristics of food or concern about an aversive consequence of eating. So many children avoid food due to a variety of sensory characteristics. Top two seem to be touch and smell. And the top aversive consequence of eating is usually eating associated with throwing up. And so if you have a child that had one of those experiences and has now paired eating with vomiting, it's likely that they could develop this disorder. You're also going to see a persistent failure to meet appropriate nutritional or energy needs associated with one of the following. So one of them is significant weight loss. However, that's not a the be all end all sign. A lot of the children that I see actually don't have a concern with weight. And so just because your child is still growing and gaining weight does not necessarily mean that they aren't struggling with a feeding disorder. Significant nutritional deficiency. They've cut out full food groups, right? They're not getting in the oral intake that we're looking for. Dependence on enteral feeding or oral nutritional supplements. So they have a tube, or their primary intake is something like Pediasure. And really the biggest one for me is this marked interference with psychosocial functioning. How is that impacting the life of the child and the life of that child's family around them, right? So we're going to talk about that more throughout this presentation and what food uh, challenges really can impact across the board. So sometimes there are children that don't actually meet the criteria for ARFID for one reason or another, but may still be struggling with feeding difficulties. And so if your child is struggling with mealtime but doesn't meet the criteria for that formal diagnosis, they could still benefit from feeding therapy. And I still highly recommend reaching out to a professional if some of the challenges that you might be struggling with are things like transitioning to new textures. So maybe from bottle to baby food or baby food to table food, self-feeding, learning how to use a spoon or a fork they seem to be struggling with or always wanting mom or dad to feed them. Chewing is a really big one for a lot of families where the child is interested in eating, but seems to have difficulty managing the food inside their mouth, and or mealtime behavior. So we want to really make sure that mealtime is as pleasant as it can be for everyone. And we know that sometimes certain children that are struggling with eating for one reason or another could make that more challenging. So, what are typical eating behaviors? Because that will be a question that comes up all the time. So, I'm not sure whether or not my child has a challenge or might have a feeding disorder. How do I know what is typical? So, typical eating behaviors for toddlers and young children. The first one is going to be changing preferences. It is okay for kids' preferred foods to change. It shouldn't mean that they're fully dropping other foods, but variation is okay. I love strawberries this week. I love bananas next week. Now I really love chicken nuggets. Things might change, but it doesn't mean that they're getting rid of those strawberries and bananas just because they're really excited about chicken nuggets. Fluctuating portion sizes at different meals. So some kids aren't as hungry at breakfast and maybe starving at lunchtime. Each meal doesn't have to have the same amount, and that's okay. It also doesn't have to have the same portion of each food at each meal. So you can have more of a preferred food and less of a non-preferred food at a meal, and that is okay as long as they're getting in those nutritional requirements. Changes in eating behavior when sick, right? Everyone's food intake fluctuates when they're sick. This is completely normal and it should not be a sign of concern unless that eating doesn't return when the child is starting to feel better. We do not expect that a child who has the flu or a stomach bug or something where they're just feeling yucky to keep up with their same intake that they were having when they weren't feeling sick. Most toddlers and young children require involvement and interaction to eat. It is not typical to expect that they will be fully independent. They need that engagement for almost any sustained type task, right? Anything that we ask a toddler or a young child to do, we are usually needing to follow up with them or stay with them on it. We wouldn't send them into a room and say, clean this whole playroom and walk away and expect that the child would finish that. It's the same that we can't necessarily expect that they're going to sit at the table and consume their whole plate of food without engagement from somebody else. Cool. And as long as concerns don't last, it's really common for a lot of toddlers and young children to go through short bursts of phases. Food intake fluctuation is common. It could be sickness, like we already talked about, teething, a big family change, like a move or an addition of a sibling, traveling, ooh, backwards. Um, all of those sorts of things can have some short bursts of food intake fluctuation, and that's okay. You just want to look at the duration in which that is happening as the event ends or becomes more common. Are you seeing that child's food intake return to normal? If yes, then there's no immediate need for concern. All right. So then we're going to look at this difference between picky eater versus a restrictive eater. This will also come up as a question a lot. Isn't picky eating just a normal phase versus, what could be something more? All right. So, picky eating absolutely can occur and could be a phase. Restrictive eater, it is very rarely a phase. It is really not common that they will just grow out of it with the passage of time. So, first thing we're going to look at is this decreased range of variety. Oftentimes, a picky eater still has about 30 foods or so in their repertoire, where a restrictive eater is going to consume less than 15 foods. And most of those foods typically fall in the snack category. Picky eaters will experience food burnout, but they can regain. So maybe they really loved eating peanut butter and jelly sandwiches. And then they said, listen, mom, I've had a lot of peanut butter and jelly sandwiches. I want to have a ham sandwich. Right. And so you start having ham sandwiches It doesn't mean that you can't intermix a peanut butter and jelly sandwich in there and they'd be okay with it, but they wanted to be able to have that change and not have that same food every single day. Oftentimes, with a restrictive eater, they're going to attach onto a food that they really, really like. They're going to eat it for a period of time. They're going to hit an end and that are going to burn out on that food. And oftentimes, you cannot put it back into their repertoire. A picky eater is going to allow food on their plate even if they don't want it. You're not usually going to see heightened anxiety around that food being there. However, for a restrictive eater, they're going to have more difficulty allowing that food on their plate if it's not part of their accepted food list. You're going to see a higher level of anxiety around mealtime, especially if non-preferred foods are in front of them. A picky eater is going to have preferred foods from each food group and texture group, whereas a restrictive eater is going to typically refuse entire categories of food. So a picky eater may prefer strawberries to bananas, or they may want peas instead of carrots. Oftentimes, a restrictive eater is going to say no fruits or no vegetables or no proteins and have full food groups that they are not consuming. Oftentimes, a picky eater is not usually refusing their food based solely on brand, color, or texture. But that is absolutely the top three that we're going to look at from a restrictive eater is that the brand, color, or texture of that food can be the reason for the food refusal. Oftentimes, a picky eater will eat family dinners without tantrums. You may have to adjust some of the foods that are on their plates, but they can sit there at the table. They can have other people eating different foods, even that they're not eating around them. And it's usually not the cause for a tantrum. Whereas often a restrictive eater is going to be more likely to engage in tantrums or try to run away or not even come to family dinners whenever possible. It's a real challenge for them to sit at a table with other people also eating. And lastly, with a picky eater, usually research suggests that they will accept a new food after about 10 exposures. So the continued practice of, taking small bites of a food or having it in front of them usually starts to spark their interest, and they are more willing to give that food a try. Whereas often a restrictive eater is not going to be accepting new foods based solely on exposure. All right, so misconceptions about eating disorders. So the first one, I'm sure you've heard of all of these, but the first one being don't make a big deal out of it. They will eat. Most children that are struggling with eating challenges require intervention to eat, and without it would often starve and would lead to hospitalization. It's happened, unfortunately, more than once with kiddos that I've worked with that end up needing a feeding tube before they get to therapy because they were given advice not to do any sort of intervention. The second one is just give them a calorie booster to increase weight. So calorie boosters are meant as a short-term solution, and they really should be used for medical need or while you're waiting for therapy to occur. It should not be the overall solution for a child that is refusing oral food, because the reality is it's not something that's great to sustain on for a significantly long period of time. And it's going to make it more difficult for them to transition off of that and onto regular textured foods. The third one is they have autism. So, of course, they have a restrictive diet. And it is common for autistic children to struggle with a restrictive diet for a variety of reasons. That's 100% true. However, it doesn't have to be something that's just accepted. With therapy, autistic children can absolutely increase the variety of their diet and really often enjoy those new foods that they are eating. They'll grow out of it. So if a child is exhibiting feeding challenges for a long duration of time, they will often not grow out of it. And it can often become more dangerous because the longer that a family is waiting for that intervention, the more challenging that the therapy is going to be for the child, the longer time that they've had that aversive reaction towards food. And the last one on the list today is because of sensory sensitivities, they can't expand their diet. Sensory sensitivities are extremely common in children, especially in children with autism, as I'm sure a lot of us know. They may have particular textures that they can or can't manage, or special rules about how food is to be presented on their plate, or to struggle around certain food smells, right? All of these things can be worked on in feeding therapy. And a lot of the kids that I work with that are able to verbalize their thoughts will often say that after therapy, they feel so much more relaxed around the dinner table. And so, oftentimes, the sensory sensitivities that we accept rather than challenge are actually causing more anxiety than calm. And so, even though sometimes we think that there's a benefit to accepting their sensory sensitivity and allowing the avoidance of certain foods, smells, textures, whatever it might be, it's actually, increasing their anxiety around mealtime. All right, so let's look at some red flags. So the first red flag that we would think about when we're looking at a child that may be struggling with uh, feeding difficulties, a child that grazes all day. So this is a child that doesn't necessarily sit for any meals. They are snacking throughout the day and usually in short bursts. So they'll run over, have a few crackers or chips, go back to play or whatever they might be doing, and then come back for more. So they're constantly seeking the food, but they're not actually eating a portion of that food at any one sitting. And oftentimes, when they come to eat, they're not actually coming to a table with a chair and sitting down to eat. They're usually just grabbing it on the go. Gravitating towards snack foods. So a lot of foods that are not nutrient dense type foods, a lot of just plain, sugar, bland foods, usually not foods that have a lot of substance to them, usually snacks or sugary type things. Avoid socialized meal times, group snack, lunch. I see this a lot in the preschool setting, in ABA clinics, or in those elementary schools where kids will run away as opposed to sitting with peers at a table to eat because it's not enjoyable for them. It's not pleasant. They don't want to be eating. They don't want to be around other kids that are eating. So that could certainly be a red flag of a potential concern. Only eats the same foods and flavors every day, isn't open to trying new foods. So, I mean, we've already been talking about this, right? But if they have a very rigid diet, if they are looking for the same item each day for breakfast, lunch, dinner, and they're not open to challenging that variety, that could certainly be a red flag. Exhibits extreme crankiness, intensity and refusal, or behavior and tantrums. One of the things that we don't often put together with a lot of our children is that food intake impacts their mood, impacts their functioning the rest of the day. And so the first question I ask when I see families that has a child that has a lot of just struggling behaviors throughout the day is, what does their food intake look like? Because oftentimes they're hangry. They are having this feeling of hunger. They don't realize that it's hunger, and it's having them act out in different ways. They're going to be short-tempered. They're going to be more likely to have long duration tantrums. And they're just going to be overall cranky. And so, if you're seeing that, it could be a sign of their food intake difficulty. The flip side of that is lethargic and has difficulty paying attention. So for some kids, rather than having that cranky tantrum response to lack of food intake, it can be the other way. They look just tired all the time. They don't want to get up and go play outside. They struggle to sit and do homework or pay attention in class, or pay attention to an activity. If they're in perhaps an ABA clinic, or they're getting speech or OT, and you're getting feedback from the therapist that the child's struggling to attend to the tasks during those sessions, that could be rooted in their food intake as well. And experiencing constipation, right? One of the first things we look at with constipation is the food intake. What does their drink and food intake look like? And oftentimes, kids that are experiencing constipation struggles, it is linked back to what they are eating. All right. So, is feeding therapy something that you might want to consider for your child? So, let's look at what behavior based feeding therapy can address. So, we can look at increasing things like acceptance of food and liquid, texture and variety, volume of food consumed, right? How much, that portion amount, self feeding skills. Mealtime consistency is a big one to increase for families. Being able to establish routines for mealtime is huge, really, for all of our children, but especially autistic children really thrive on that routine. And it is really beneficial when they know what to expect when it comes to mealtime, as opposed to getting meals on the go or being a changing schedule every day. And also looking to increase caregiver education and skills. So a lot of times families will come and say, I have no idea what to do. Or the way mom runs a mealtime versus the way dad runs a mealtime can look very different. And so we want to make sure that everybody's on the same page and everybody's following the same procedures when it comes to mealtime. We can also look at decreasing refusal behaviors around mealtime, right? So it's going to be a big one. Packing. So if you have a child that puts food into their mouth and kind of holds it into their cheek, chipmunks those cheeks, that can certainly be something we can work on. Expelling, so spitting out that food. Gagging or vomiting is often associated with some of our children and their struggles with mealtime. And so that's something we can work on decreasing. Often we need to look at decreasing meal duration as well. I have families that say that they will sit at dinner for an hour and a half waiting for their child to be able to eat. That's not fun for anybody. And we want to be able to look at getting that meal time down to usually about 30 minutes. Seems to be reasonable for like a family dinner time. And that's certainly something that we can work on in therapy. As well as the flip side of what I was just talking about, we want to decrease those caregiver inconsistencies. So mom lets me get away with this, dad lets me get away with this. We want to be able to make sure that everybody's on that same page. All right. So I often get asked about personal choice when it comes to a child's eating. My answer is usually a child can be part of pre-selected choices, things like, do you want peas or carrots for your vegetable tonight? But not the overall choice of, do you want to eat vegetables? Okay. Um, I equate it to other non-negotiable type tasks. As parents, we set boundaries for our children all the time, right? There are certain situations where our kids may not want to engage in a certain activity, but we require it due to their health and safety concerns. So things like buckling in the car seat, staying out of a busy street, taking medication, being protected from the sun, right? Those are all things that at one point or another, the child's going to fight over in some capacity. But we know that we have to create that boundary and set that guideline to be able to say the expectation is it might not be the most fun, but we have to be able to do this. Um, One of the examples that I give, we look at this like the first one being buckling in the car seat, right? If your child was feeling uncomfortable in the car seat, did the toddler arch back, didn't want to get buckled, or insisted that they wanted to sit next to you while you drive in order to feel calmer, I'm guessing, I'm hoping, that you wouldn't really allow that, right? You would hold the boundary and you to care about their safety. They need to be buckled and they need to be in the back seat of the car in order to be in the safest position. And so you would come up with things, maybe, let's get in the car, and if we can buckle up really great, right? We'll get a lollipop when we get to the store, right? You might have a reward, a reinforcer item for that child to be able to earn when they complete that more non-preferred or not fun task, but you're going to hold that expectation that they need to be buckled in their seat. And really, when we think about it, eating in meals and exhibiting appropriate mealtime behavior needs to be on that list as well. The same goes for feeding. It may not be a preferred task. It may be more of a challenge for some kids than others, but it is essential to maintain a body's health. The longer that a child avoids certain foods, the more heightened of a response they are going to have when they are presented with that food again. So the quicker that we can identify that there might be a challenge, or they might be going down a road of some food refusal, and we set boundaries and limits around that, uh, the more successful that child's going to be with eating. So what would you look for in a feeding program? You want to look for a feeding program that is focused on consumption and appropriate mealtime behaviors rather than playing or engaging with food as part of therapy. The reason that I say this, the biggest reason, right, is that that's ultimately what we want the child to do. So a child that learns to hold a strawberry or play with a strawberry is not any further along in getting in that nutritional intake than a child that was just refusing that food altogether. They're ultimately using it as a toy. The other thing that I think about, and I often share this story with people that I talk with about this sort of experience, is thinking about how, when we really engage and look at food, um, it sometimes can make it more unpleasant. So I think about a raspberry and the fact that I absolutely love raspberries. I could eat them all day long. But if I picked up a raspberry and held it in my hand, and right, and really looked at it and investigated the hairs that were coming off of the side of the raspberry and how bumpy it is, and how maybe one side is squishier and one side is harder. If I had to look at it, to hold it, if maybe I had to touch it to my tongue, um, it, it might start to skeeve me out, and then I might not be as interested in eating it. And so when I think about a feeding program or working with kids that already are heightened around food, is that actually the less engagement and the less interaction that we have with the food prior to putting it in our mouth, oftentimes the more likely it is that it's going to be a tolerable food for them to be able to eat. You also want to look for a program that's going to meet the child where they are and shape the food choices for therapy sessions accordingly, right? So you can't start with a piece of broccoli if they're only eating snack foods. We have to find those snack foods and find their closest corollary partner to some regular table foods, and slowly merge our transition off of just peanut butter crackers to ultimately get to a peanut butter and jelly sandwich. Um, Using positive reinforcement, right? We always want to find things that the child enjoys to reinforce when they are doing the right thing. We do that in feeding. We do that really across the child's whole day when it comes to activities that they're not necessarily that excited about engaging in the beginning. Set mealtime expectations comparable to other activities of daily living. We have behavior expectations for our child in a variety of different areas of their day, and mealtime should be one of them. You also want to really make sure that that feeding program is going to include parent and caregivers in the treatment process, right? Maintaining the progress that the child makes in therapy is going to be really challenging if the parents aren't involved. You guys as parents are the ones that are spending the most amount of time with that child and eating, and it's important, it is essential that you are a part of that treatment process. All right, so tips towards appropriate eating. So here are some things that you can do. The first one being set designated eating times at home. So avoid continuously offering foods in hopes that they will eat at some point. That is going to lead to that grazing, and it's going to make it challenging to be able to uh, bring that hunger out for that child. So we want to designate set meal and snack times and only offer foods at those intervals so that they can feel hunger. And it will also allow your child to set an eating routine. They will know when their meals are coming and when they're going to have access to that food throughout the day. You also want to look at presenting opportunities for similar but different foods already in their repertoire. So looking at a new flavor or brand of yogurt, a different type of chicken nugget, a varied chip flavor. One of the things that we see oftentimes in kids that have significant restrictive eating is that even those slight variations of change can really be a challenge. And so I will often recommend for families that are in earlier stages of struggle, or even families that aren't even seeing any challenges at the moment, to start doing some of those changes and variations right from the get-go so that that doesn't become one of the areas of concern. We would see with a lot of kids that even just changing the the branding from the same company can impact that child's willingness to eat that food again because of their significant rigidity around that type of food. And so we want to be able to maintain the flexibility in their diet. The third thing is going to be start small for new skills. Pick one day a week to do a new food introduction and slowly incorporate the foods they do well with into meals during other times of the week. You want to make sure that then you're not just giving them new foods all day, every day, because it's going to make it difficult for them to feel comfortable coming to the table. You also want to make sure that when you are going to present a new food, that you're doing it slowly in the sense that it's probably a smaller bite. Um, excuse me, and that you're setting a specific day or meal that you're going to work on those new foods, and that you also have preferred foods in that meal as well, so that they have things that they already are familiar and comfortable with eating. Not all portions need to be the same. That goes across the board, even as they continue to expand their diet. What we're working on teaching, and what most of us as adults recognize, right, is that there's foods that we have to be able to consume in order to get good nutrients in throughout the day for our body. And then there's foods that we actually like eating. And that's okay. It's okay to be able to have bigger portions of the foods that we like, as long as we're also having some amount of portion of the foods that are really essential for our body and for our growth. Avoiding engagement with food outside of consumption. So I highly encourage that you find non-food mediums to engage in sensory play with, things like shaving cream or Play-Doh versus Cool Whip or pudding, and that you're removing food items from their reach if they are playing or squishing or throwing the food. It happens a lot with the kids, right? And you know, they'll get mad at mealtime and they'll start banging on the table with those food items, or they'll start chucking food at their sibling across the table. We want to make sure that then we're not giving them access to that food item anymore, because we want to be able to teach again that food is for eating, it's not for playing or engaging in those inappropriate behaviors. All right, so I tried to hit on most of the questions that I know that had come in prior to the talk today. Obviously, we're going to get into some Q&A here now, which I think will be great. But certainly, if you have more questions, there is my contact information if you'd like to reach out for more.
Great. Thank you so much. And we have a nice amount of time now for some Q&A, which is great. So as a reminder, if you're an attendee, please enter your questions in the Q&A box if you're on Zoom. And if you're on Facebook, you can enter questions in the Facebook chat. But but we've already received quite a few. So let's get into it.
Good.
So one thing that you pointed out on one of your later slides is, the importance of the parents and caregivers being involved. To what extent, if you're in a situation where there's other family members or multiple caregivers in the home, like how many people should be, sort of reinforcing these therapy takeaways and eating habits, or should it really just be one point person?
Yeah, so sometimes it might have to start off being one point person, especially depending on the restrictiveness of the child and the development of that protocol. But I highly encourage, just like we talked about changing brands and flavors of different foods, is you want to be able to change environments and feeders that the child is presented around. So it's great if he'll sit and eat with mom, but if dad's home 2 days a week or he's going to grandma's during the afternoons, right? We need to be able to have all of those people involved in those sessions as well. So I love when grandparents or teachers are showing interest in wanting to be involved in that child's food therapy, because the more people that are involved and the more people that are following the same guidelines that the parents are, the more successful that child's going to be.
Great. And sort of kind of completely different question, but just as we've been speaking, a few people have just asked this. So what are your recommendations, or how can you maybe help stimulate appetite in a child that perhaps just has low appetite? It's not necessarily picky or restrictive, just isn't interested in eating, or is perhaps on medication that has now suppressed appetite?
Yeah. So, I mean, first things when it comes to anything that there could be a potential medical concern for, as I always say, make sure that you're checked out medically first, right? And make sure that there's no internal reason physically as to why your body is not able to eat. If it's really due to more of something like an ADHD med, where often it will lessen your appetite or lessen your interest in eating, is that it's working on teaching them to look at eating as a task, as opposed to just thinking I'm full and I shouldn't eat anymore. And that really is like a tricky one, and one that I really recommend, working with a professional that's familiar with this, to be able to make sure you're doing it effectively. But if we think about, like, when we send a child to go clean their room, right? They're bored after a couple minutes because it's not a preferred task for them. No child really wants to clean their room. When eating is not enjoyable to somebody, and that often happens with a lot of our RFID kids, they don't have that same internal drive or interest to eat. It's not a task that they want to sustain doing. And so it's not so much that their body can't handle it. Again, if they've been medically cleared and there's no concerns, their body can't handle it. It's more that their mind is wanting to take them somewhere else. And so it was a slow progression of just slightly introducing more and more portion to their meal until it gets to that level that the nutritionist or that the pediatrician is saying is where their oral intake should be.
And correct me if I'm wrong, but I believe you mostly work with younger children.
It
or
depends, up through teenagers.
Okay,
Yeah.
great, because I was going to ask about teens and just wanted to make sure that
Yep.
you felt comfortable answering that. But so what are your thoughts, or what is there any differences in the approach to working with teens who have, restrictive eating?
Yeah, I mean, so certainly, right? Like the program that would be done for a 2 or 3 year old is going to be very different than a program that would be done for a 13 or 14-year-old. Absolutely, there's going to be differences there. those teenagers are absolutely going to be more involved in the process and in the choice of foods that they're going to be willing to try, right? Where we look at we have to include vegetables into your diet. Here's a list of 10. What are the 3 that look most tolerable to you, right? I can do that with my 13-year-old. I wouldn't be able to necessarily do that same thing with the 2-year-old. So there's certainly treatment approaches that will work for that teenage level as well. It actually seems to be most of my current clientele seems to be that older age population, but it can be effective, through the span. I specifically work with kids that are eating table food, so at least about that 6-month age to about 16-ish years old.
Another interesting question we've got from a few people is food avoidance or restrictive eating as a result of trauma. Is that something that you have seen in your work or have had to, adjust therapies for that?
Yeah, so that's not uncommon, right? Is that there's a choking incident and it shuts them down, being really scared to then consume any food. I once had a child that was so scared he was actually spitting his saliva into a cup because he didn't want to swallow his own spit. He was that scared. So with situations like that, again, you have to meet the child where they are and be able to start really, really small, and praise those little gains along the way. It's not going to be, a quick 1 month fix, because you're looking at little successes over a longer period of time. You have to be able to have them build up that trust again with food. But again, balancing that with our body needs oral intake. And so without it, we end up on a feeding tube or, some other sort of medical intervention in order to get the nutrients in so that our body doesn't just shut down. And so depending on the age of the child, it's really finding that balance of what that approach looks like with the trauma. But I've had a good number of kids that have been able to overcome their fear, whether it be from choking, severe vomiting. I had one of the clients actually went into sepsis after eating. And so she really did shut down to the point of being 13, getting down to 60 pounds, needing that NG tube, and being able to work through a feeding therapy program and get herself off of that tube and back up into appropriate weight. So there is absolutely help to overcome that restriction that follows food trauma.
Great. Thank you. Going back to might have been the first question that I asked about, who should really be involved in reinforcing these, the takeaways from therapy. Is there an extent to which that individuals at the school, whether that's teachers or, cafeteria staff, should be involved in this? For instance, if your child will eat at home, but outside of the home, they struggle to eat or refuse.
Yeah. Yes, I would say that that question varies, right? It's going to depend on the interest or willingness of the school, right? Certain schools are more willing than others to participate when it comes to feeding programs, especially when we think about oftentimes lunch is the break time for a teacher. And so to be able to have the need to follow through, you sometimes have to look at getting an aid support in the classroom or something like that to be able to help that child. It's usually not something that we would start an intervention in a school setting. We would start the intervention in the home setting and establish it and master it there, and then transfer it to the school so that they're working on skills that they've already mastered in a different environment. Because school for most kids is not it's not the place to work on feeding just because there's so much going on, but it certainly can be a transfer of care as the process is moving.
And then just sort of, I guess, a general question, maybe we should have started with this one actually, is who can diagnose or what specifically qualifies an individual as being a restrictive eater or having ARFID? And like, where can people start with, if they suspect that
That there's a
perhaps
challenge.
they need some sort of official diagnosis to then be referred to therapy, depending on insurance and things like that.
Right. So that would be my first point, right? Is it really depends on the provider that you want to go see, and whether or not they're taking insurance. Unfortunately, a lot of quality food therapy is going to be a private pay provider, because insurance makes it really difficult to provide that quality care. So oftentimes insurance wants to restrict the amount of hours or sessions that a child can qualify for. And when I look at feeding therapy, you can't always predict at the beginning what exact amount of services that child is going to need to be able to succeed. And so I know myself and a lot of the other providers kind of in my wheelhouse of people that I work with, have gone to more of a private pay model to be able to provide the quality of care that the family and the child deserve. With that, then oftentimes those providers are doing their own full evaluation, and you don't necessarily require a formal diagnosis of something like ARFID. And again, some children don't necessarily even qualify for that diagnosis of ARFID, but still would benefit from feeding services. So I say start with your pediatrician, although I say that with some hesitation, in the sense that what the feedback I get from a lot of families that come to me is that if your child is growing effectively in height and weight, is that the pediatrician is not flagging the food refusal as a concern, and will often push off a referral to a therapist. And so you can certainly start there. But as I mentioned on one of the slides I was talking about, is you really want to look for uh, a behaviorally based program. So you want to look for a program. The first question I would always ask is are we focused on consumption? Are we focused on the eating of the food? Or are we focused more on the interactions with the food? Because those sensory based approaches, the interactions with food, the touching, licking, kissing, playing with the foods, just don't often yield the results that families are looking for. I have a lot of families that will come to me after being in one of those programs for a period of time, and not finding the success there. So you want to be able to either look for, you really want to look for a clinician that is specialized in feeding, that has a behaviorally based background that's going to be using that approach towards your feeding therapy.
And, in the vein of, you mentioned the sensory components to this, and I feel like you gave a really great example of, I love raspberries, but if I look at it for too long and think about it too much and, see those little hairs, I can kind of convince myself that I don't really want to eat this. I don't think I like this. Do you see, so that's obviously more of a sight and feel when it comes to sensory, but do you see restrictive eating that's more related to like olfactory and smell issues, and how, any tips, or how do you sort of work with children that are having more issues in the smell category?
Yeah. So I think again it would depend, right? Are the things that they are aversive to smelling required things that they need to eat, right? So like I know, I have some kids that I work with that just absolutely are repulsed at the smell of broccoli, right? They don't like it. They don't like mom to cook it. They don't want to have it anywhere near them. And my initial answer would be then we don't actually have to even work on that if they're willing to eat a variety of other vegetables, and broccoli is really something that is just the one thing that they need to avoid. If it was something that the child really wanted to work on and they wanted to be able to overcome that, they want to be everybody else in the family loves broccoli, they eat it all the time, and I want to be able to feel more comfortable at the table, then we would look at doing some desensitization, really being able to work them closer to being able to tolerate those smells. it's tricky, and it would be, dependent on the child, but my philosophy is always meet that child where they're at and pick our battles, right? Being able to find what are ones that we have to be able to combat and overcome, and what are ones that are not necessarily going to have that impact on their functioning.
And is that something that you see a lot of, where there's a child, or maybe it's more teen, somebody who's a little bit older, that's really wants to try and enjoy the food that they're observing others enjoying, and is it sounds like you said it is kind of a case by case how you work with them to do that, but that's something that you see?
Yes, and those are the most fun for me, because the reality is, more often than not, once they get over that hump, once they get that courage to be able to put that food in their mouth, more than not, for a lot of those kids, they actually realize it's good. I just tracked data for a presentation that I did for one of my preteen clients, and I had her rate her foods from the first time she put it in her mouth to the most recent time that she was eating it. And most of her foods, I think it was 16 out of the 20 that she tried, started off at that first presentation. As soon as she had hit her mouth, the food she had never had before was a 3. And most of them worked their way up to 4s and 5s. She had very few 1s and 2s. And so it was telling me, right, that like she had this huge aversion and fear, did not want any of these foods before we started services. And when it became an expectation that we have to look at this food list, we have to pick these foods, you're in charge of picking, you're in charge of the order, but we have to do them. And she, worked herself to be able to put those bites of food in her mouth, is you saw just a change in her face to be able to go, that is actually good, right? And I can like that. What actually happens with a lot of our kids without us necessarily knowing it is we have a gag reflex on the tip of our tongue. And what happens with a lot of kids with food refusal, or kids that are trying to force themselves to like something, is they'll take a little bite and they'll stick their tongue out, right? And try to touch that food. Ooh, and they'll gag. And sometimes if you have a really sensitive gag reflex, it makes you vomit, right? And so you go, "Ugh." And then they go, oh, see, I can't eat that food. I can't do it. It's gross. It's awful. It's disgusting. And I say, we're going to try that again. But now this time we're going to put it in, we're going to put it right onto our teeth. So we're going to bypass that little gag reflex that's on the tip of our tongue, and we're going to start chewing it. And then that's allowing you to get that flavor and get it swallowed back while not having that initial gag response. And once, obviously we have to do that with our older kids, but once those older kids are starting to realize how to consume those foods, uh, they really seem to enjoy it. I had, one boy I still think of now that, uh, had a background on his Zoom camera, and it was, I didn't die. And he, had a big smiley face at the end and was so excited to, keep trying these foods that he used to think were so terrifying. And now he was feeling so good about for every day he would log in for sessions.
That's great. And I'm wondering too, if you've observed, you have a younger sibling, older sibling. Does it help with, the older sibling loves broccoli? I think that's a good example. I
Yep.
think a lot of kids probably shy away from broccoli for one reason or another.
Yep.
But if older sibling likes broccoli, is maybe helpful to, show to the younger sibling, oh, your brother likes it. Look how much he loves it. And does that help them ever? Or
Sometimes I'd
yeah.
actually say it works more in reverse, that once a
Mm.
family with, we'll call it the squeaky wheel child, right? The child that's having these higher level of food restriction issues is in therapy and developing a mealtime plan and a protocol, is that families actually then apply it to everybody in the family. And so even though the other siblings may not have been as severe or significant as the child that they reached out for, they were still experiencing some pickiness or some other issues. And so now it's actually the child that's receiving therapy that's eating the broccoli, and
Right.
the other ones are going, oh, if he can eat it, then I guess I can eat it, because it should be good too. And that they will be more likely to get on board with the process.
Oh, that's really interesting. And I guess it benefits everyone in that way.
Oh,
Yeah.
yes, for sure.
Um, it's something that was interesting that I myself have observed with children that I know, and I'm sure many of us on the call have observed, something you pointed out is the gravitating toward the snack foods.
Mhm.
So I guess sort of a two-part question is that there any understanding of as to why restrictive eaters gravitate more towards snack foods? And then I guess the second part of the question is, do you see sort of the flip side of that ever, where there's restrictive eaters are only eating, protein, like, or maybe only vegetables? And how do you sort of balance that when they're eating the things that are good for them, but maybe just to an extreme that's not so good anymore?
Right. Yeah, yes. Well, so we'll answer the first one, right? Why do most of them end up gravitating towards snack foods? I'd argue, especially when we think about the sensory input of food, and we think about a lot of kids with autism that are struggling with eating, is that oftentimes snack foods are crunchy, and so they're going to give you a lot of that feedback as you're eating. You're hearing that crunch, crunch, crunch as you're getting it down. It will usually have some sort of a strong taste to it when you think about like a Dorito or a Cheez-It, right? Or something that's going to give them that salty um, feeling. So they're going to be able to have those sensory experiences as they're eating. It also goes down fairly easy. So when we think about a lot of things like proteins seem to be the most challenging for a lot of our kids, a lot of meat. It's really difficult to chew. And when we think about especially kids that are just on the go, or feeding is just not that exciting for them or not that enjoyable, they want the least amount of effort possible. And so they're going to be able to take foods that they can just shove in their mouth or swallow down, and be able to go back to that more enjoyable thing that they want to do. They don't want to have to sit there and chew, a chicken nugget or a steak or something like that for an extended period of time. Um, to your other question of, are there some kids that their restriction is more on what we would look at like as healthy foods, right? Are there more like nutrient foods? Yes, but they're still usually like disregarding food groups. So I do have a lot of kids that will eat, let's say, like a huge volume of fruit. Usually not vegetables. I don't see kids that are like
Yeah.
loving vegetables when they come to me, but I do see a lot of fruit, and I look at fruit as one, it's sweet. Again, that response level is going to be low. Usually fruit is pretty soft and will go in fairly quickly. But even if they're eating all of that fruit, that's great, but our bodies need more than just fruit to be able to sustain themselves. And so we really I strive for all of our families, and whether it's the younger kids where I'm working more with the parents, or the older kids where I'm working more with them, is that we're looking at all of those food groups and making sure that we're having at least a handful of foods that the child is comfortable with and willing to consume in each one.
Great. And I know we're at time, but real quickly before I, just sort of close us out, do you have any resource websites, pamphlets, or anything you could recommend? I know some people were asking that in the chat as well, for
Yes.
Arid specifically.
So I mean, for my thing specifically, definitely my website has a lot of great information. I strive on our Facebook page to share a lot of information and resources about ARFID, as well as other pediatric feeding concerns. And we really try to share articles and be able to give families all of the information that they may need. So in the interest of quick time right here, I would say start at Focused Approaches website. And we really work hard to be able to disseminate all of that information out to families and caregivers.